So Brian, one of the things that I've certainly seen in my practice is we're starting to use these agents, these targeted agents, with some different schedules and dosing opportunities that may make it a little bit more easier for the patient to tolerate. I'm using sunitinib on a 2-in-1 schedule a lot more often than I'm using a 4-in-2. I've experienced over the last several months with axitinib that people tend to hit the wall after a certain period of time, need a little bit of a break, but then with stopping can restart. How do you integrate that into not only the database of agents like the COMPARS trial, which was a very fixed dose and schedule, to how you're managing these patients kind of in a day in and day out basis?
Yeah, so good question. I think really sort of a hot topic in the last year or so. And as I think you and I have discussed before, it's a little embarrassing that after 10 years of these drugs, we're, I think, now just figuring out how to give them. We sort of got so locked into, for instance, the 4-2 schedule of sunitinib, and weren't really creative in thinking that, gee, the inter and intra-patient variability for these oral agents is huge. And it just sort of, for whatever reason, took us a while to get to a place where we said, okay, we've maybe maximized efficacy. We've maybe reached an efficacy plateau with these drugs as more trials and data came out. So now can we get creative about how to individualize dose for an individual patient? So we use a lot of sunitinib 2-1 scheduling. You know, subjectively, it's very well tolerated. There's retrospective data that would support that as well. And we're about to take part in a multi-institution single-arm phase 2 trial to prospectively test that. Again, it'll be only a single-arm trial. It's not a large randomized, won't be label changing, but it will at least provide some prospective data around that. Same with axitinib, for sure. We give patients breaks all the time. And I think, again, as we've sort of been able to step back on what these drugs are able to do and not able to do, really the goal is to treat people as little as possible, right? We should give them as little possible drug to control disease. We can beat them into submission, but they're not gonna shrink anymore. They're not gonna achieve CRs in general with these agents. So I've almost sort of shifted my focus to not giving as much drug as possible, but to give as little as I can get away with, including breaks. We have some data at this year's ASCO about patients who've taken breaks, largely on sunitinib, but also on all the agents. And you really find that the median initial length of break was 16 months. These are highly selected patients, patients who were doing great on therapy, obviously, but similar to our observation study, to me it's about taking advantage of the natural history of this disease, which for some patients can be quite indolent.
Yeah, I think one of the amazing things that I've seen in my practice, and Jan and I have been at this for a while, is I have patients coming in now telling me it's time for a break. They actually say to us, you know, I think those side effects that cause me to have a break the next time, it's creeping up on me, and I think it's time. And it's almost as though our learning curve about how to deliver oral drugs to patients with kidney cancer has evolved over time as well. Do you find that in the community setting, Chuck?
Yes. I've anecdotally had several patients who've had very prolonged breaks, and they will often come and tell me when they need a break. On the other hand, I have some patients that are so worried about progression when they stop the drug, they're afraid to. I have one patient anecdotally who had a solitary brain met treated with gamma knife in 1999, had lung mets that went into complete remission on sunitinib, and he's been on sunitinib 6 years now and refuses to stop. So.
Yes, people certainly do become somewhat addicted to their need to receive that medicine. Jen?
Well, I would concur with that. I've had a similar experience, and I actually do believe I've seen control of brain mets with even low dose and not even daily sunitinib, where I've gone to 5 days on, 2 days off kind of schedules for people who refuse to stop but need some ability to take a break.
Brian?
I just wanted to add, I mean, in our experience with treatment breaks, there were occasional patients who did get into trouble on a break. So, you know, you do have to be mindful for people with sort of more dangerous sites of disease, be it brain or paraspinal or bone or something. I think it's okay to take breaks in those folks, but my threshold to reinitiate is lower, and they need to know that at the first sign of trouble or pain or something, they need to contact me. If it's in between scans, if I'm not scanning them every 4 months or whatever, they need to contact me because those folks can get into trouble.